So at this ASCO GU 25 meeting, we are reporting the final analysis of COSMIC-313. And so COSMIC-313 is a first-in-class trial because it's the first triplet combination that has been tested in a randomized phase 3. So Cabozantinib plus nivolumab plus ipilimumab, we're going to name the triplet, versus nivolumab plus ipilimumab as one of our standard of care plus placebo, we're going to say the doublet. And so what is presented at this meeting is the 45 months follow-up, is the final analysis, which confirmed the progression-free survival benefit that we had at the first analysis after only 15 months follow-up. So the hazard ratio for PFS is 0.8, and we have an improvement from the doublet 11 months median PFS to 16 months PFS. So a clear benefit in adding cabozantinib. However, with regard to overall survival, there is no difference, and the hazard ratio is 1. So basically, no improvement in overall survival with the triplet strategy. So I think this is important because this trial is the first that tested a triplet. It was a blinded trial, so patients were receiving cabozantinib or placebo. And it is important because in the way you manage toxicity in such a trial, it's not the same picture to have an open label or to have a blinded trial. Therefore, what we saw in this trial is that to manage toxicity, of course, there were either dose reduction of the oral drug, cabo or placebo, or withholding one of the triplet components, such as the ipilimumab. And indeed, this is what we saw, because the median average daily dose of cabo was only 22.3 milligrams per day. Okay, so clearly a lower exposure than the 40 milligram you would anticipate. And also the numbers of ipilimumab cycles administered in the triplet was lower. And only 58% of patients got the 4 cycles of ipilimumab versus 75 in the doublet arm. So it means that running a triplet trial is not easy. It also captured the information that with regard to toxicity, having 3 drugs, 3 active agents induced toxicity. And in this case, half of the patients in the triplet arm had to discontinue one of the treatment versus only 25 in the doublet. So maybe potentially an underexposition in the triplet arm. So that taken all together, I think it's an important trial. It's a first-in-class design of triplet study. Second, it shows that we're able, with the addition of cabozantinib, to increase the progression-free survival. Third, unfortunately, no benefit in overall survival with all the limitation of exposure I have stressed. The other thing that we presented is the biomarker piece that was constructed around the trial. So here, the principle was to use the RNA-seq data and perform 2 different analyses. One is about what we call the molecular clustering that was done in the emotion program as well as in Javelin. And here, long story short, no differences based on the molecular clusters with regard to outcome with triplet versus doublet. So this is not something we can use to select for triplet, for instance. The second piece of biomarker was to use, again, the RNA-seq to do what we call deconvolution. It's to assess the relative abundance of immune cell. And interestingly, what the study showed is that there is a population that we call M2-like macrophage that seems to be associated with dismal prognosis, IMDC poor risk, visceral mets, worse outcome. And the fact that you add cabozantinib is able to revert this dismal prognosis. So it's more food for thoughts, and further investigation will be needed there. But it's great to have biomarker piece embedded in the trial. So in the subgroup analysis conducted in this final analysis, there are 2 aspects. The first one is the IMDC risk group. 3/4 were IMDC intermediate, 1/4 were IMDC poor risk. And while we saw a difference in progression-free survival in the intermediate, that did not pan out in the overall survival, okay? So that's the first signal that was looked at because we already had this signal for PFS benefit within the subset of the IMDC intermediate. And now if you look at all the subgroup analysis with regard to overall survival, there is not a specific subgroup that really stand out seems to benefit from the triplet strategy. So I think we are not able yet to find who are the patients that require a triplet strategy. from a clinical standpoint, the patients where I would like to be able to offer a triplet, if it's available, is those patients that have aggressive disease, that are symptomatic, and for which you really want to have first the VEGF-TKI response, thanks to the Cabozantinib, but also the long-term outcome with the nivolumab, ipilimumab. And so I think as a physician, we see who are those patients for which we say, oh, I'm not be able to go to second, third line afterwards. But as of now, we don't have an overall survival benefit. I think the COSMIC-313 was is a very important trial because it's the first time we're having triplets being prospectively compared to one of our combination standard of care. We have now further trials assessing triplets that are actually open label, so we don't have this blinded issue that now we realize with COSMIC-313. And I really feel that we will need to have more and more data to define who is the patient population that can derive from the strategy of triplet. The second piece of information that we're looking forward to see in other trials is the toxicity. Is the toxicity manageable with other triplets compared to COSMIC-313?